So I'm not here to talk about any new technology. I'm here to talk about the standard clinically applicable technology that we're using now in the pathology laboratory. So I'm a pathologist. I specialize in breast cancer. I do HER2 testing every day, and I'm very interested in how we define things and how we apply our standards to our clinical cases. So we're going to talk about HER2 heterogeneity in breast cancer, primarily by FISH. We've talked a lot about how heterogeneous cancers are today, and as a pathologist, I'm interested in figuring out which targets there are present in a cancer that we can potentially have a therapy for, and how we define those thresholds for predictive testing is really what's driving my testing today. This is not how pathologists used to work earlier, before we had many targeted drugs. We were doing our testing in the lab for the purpose of prognostication. So we've changed a lot of our role in terms of making patients candidates for drugs versus just saying this patient will have a good outcome versus a bad outcome. So one of our big challenges is how do we standardize, and what do we standardize to? Do we standardize to the clinical outcomes? Do we standardize to prognosis? And that's how we were initially standardizing our, for example, our hormone receptor testing. Which ones we're going to do poor? What positive threshold should we set? Or when new therapies come along, or now that we're doing predictive testing, making patients candidates for specific drugs, how do we standardize in a clinical trial setting? What happens when there's a new drug that has a similar target, but it's a new drug? Do we use the same thresholds? And so really, it's a bit of a moving target. And while cancers are evolving, we also need to keep evolving our standards. Sometimes looking at standards again is important after they've already been set, because they were originally set in a setting where there was no evidence to say what the threshold for positive should be, and it was sort of arbitrarily set. So I'll briefly talk about hormone receptors. What defined an ER-positive breast cancer was really a study done in 1999 by Craig Allred, but really didn't become standard practice until 2010, when we finally came out with some guidelines saying what the clinical threshold for a positive, ER-positive cancer should be. It used to be that labs could sort of pick their own thresholds. Should it be 10% of ER-positive cells or 50% to make this classified as an ER-positive breast cancer? CAP, College of American Pathologists, and American Society of Clinical Oncology got together and put together guidelines saying we're going to use this study. It's one of the only clinical validation studies of our thresholds. So as little as 1% of cells in a breast cancer being hormone receptor positive makes that cancer a hormone receptor positive cancer test result in the pathology lab. So that's a very low threshold. These are heterogeneous cancers we're talking about. A lot of breast cancers are strongly positive and very uniformly positive, and then you have a more heterogeneous group in the middle, and then what we've defined as ER negative. But the better you get at detecting things, the more heterogeneity and lower level of expression you'll be able to uncover. Now, when we talk about hormone receptor expression, we're kind of talking about a lower risk type of breast cancer. So, and we've got a therapy, tamoxifen or aromatase inhibitors, that are not as toxic as, say, a chemotherapy. So there's a sort of we've set our threshold really low, but we also aren't delivering an extremely toxic therapy. So we're hoping for some benefit in that setting. So a lot of what the standards, how they get applied, has to do with what kinds of therapy we're talking about. And defining a breast cancer as hormone receptor positive when only 1% of the cells is staining, may not do a good job of matching up with what our molecular subtypes as we know it in breast cancer are, like the basal-like breast cancer. If you have a weakly ER-positive breast cancer, 1% staining may not be the right threshold for defining that subtype. But we're really using drug therapy candidacy to define that positivity. So in HER2 testing, again, we initially used HER2 testing for a marker of a worse prognosis in breast cancer. And then along came HER2 targeted therapy, and really that test became the gateway for making patients a candidate to Herceptin and now other HER2 targeted drugs. But this therapy comes with chemotherapy. You don't give the HER2 targeted therapy alone. And so you're wanting to treat the higher risk cancers. So your threshold may be different than the 1%, let's treat everybody, because we don't want to be over-treating the majority of breast cancers. The threshold for positive was based on initial Herceptin trials. And so quickly, how we test for HER2, there are a number of different mechanisms, but the most classic that we're using here in the United States today is immunohistochemistry, so looking for protein overexpression, and then fluorescence in situ hybridization or other-ish methods where you're looking at the gene amplification status. And it wasn't until 2007, so fairly recently, that we standardized and set the standards with the College of American Pathologists and ASCO to say in a strict way, these are what our standards are, and every lab should be applying the same standards for their testing. And they've done a really good job of following up on that. The College of American Pathologists comes and inspects your lab and makes sure you're following guidelines. So they established those guidelines in 2007, and they recently were updated in 2013. This is how we score our immunohistochemistry stain. It can range from 0 to 1+ for a negative result. 2+ means you've got an equivocal result and additional testing is required. The FISH testing is usually the next step. Or 3+ positive means you've got strong overexpression. You can see there is some subjectivity, and sometimes you get cases on the borderline between these kinds of results. FISH testing was initially in the trials with Herceptin performed in an interesting way. So they used a centromeric probe to control for, we're looking at gene amplification. So they used a centromeric probe to control for what they thought was going to be polysomy, so multiple copies of chromosome 17. And it turns out that most of the time when you get, so they developed a ratio system for scoring. If you had a ratio greater than 2 of HER2 signals to the centromeric signals, you were considered HER2 amplified. Turns out that most of the time when you see co-amplification of both the centromere and the HER2 signal, that it's actually co-amplification of a large region of the chromosome and not polysomy. So they've redefined their definition slightly to include cases that are negative by ratio, but positive by signals per cell, so high numbers of cell, to be positive result. So there's multiple ways you can get a positive result, but a lot of it hinges on that ratio system still. And I think it's interesting the way that we score these cases. So we're talking about cell populations a lot today and how they evolve. We basically score this, instead of a % positive cells, we score it as an average. So we may, if you look in this spreadsheet, see we've counted 20 cells. And these are our centromeric signals here. Here's our HER2, and then here's our per cell ratio for our overall average ratio and our overall signals per cell. So this case would be not amplified. It's close to the threshold for positive, which is 2.0 for the ratio, but the mean signals per cell is low. So that would be considered not amplified. But if you look and say, well, if I'm defining each cell as a ratio greater than 2 as positive, 35% of these cells are amplified. But we have a negative result overall when we average them out. If you look defining, instead of using ratio to define each individual cell as positive, and you use signals per cell, which the threshold is 6, HER2 signals per cell, only 1 of the 20 is positive. So how we define each individual cell can really influence how the whole population is scored, and then the frequency of those cells really isn't taken into account. You can have some real high amplified cells in there, and they get kind of washed out in the averaging. So in 2009, there was an expert panel that got together and said, well, maybe we are worried about these minor cell populations by FISH, and maybe we should be scoring these differently. And so they made recommendations, but they knew that there wasn't much evidence out there to say whether these were significant minor populations of amplified cells. And their recommendations were, let's try defining heterogeneity here as 5 to 50% of cells with amplified ratios. And they used 2.2 because the older guidelines had an equivocal range that went to 2.2. So, as little as 1 in 20 of these cells, 5%, amplified, then it would be considered heterogeneous. But they didn't really say what to do with that. And I think those guidelines weren't adopted uniformly in labs across the country because people didn't really know what to do with that information. So what kind of heterogeneity are we talking about, and would these recommendations apply to is this intermixed form of heterogeneity or mosaic style heterogeneity where the amplified cells are scattered in a background of non-amplified cells. We're not talking about clustered cell populations, the subclones that look like they're growing out. So when I was at University of Washington, we're curious, how common are these? Nobody really asked the question, how common are these low intermixed mosaic-style heterogeneous cases? And so we looked at our cases and said, if we applied this recommendation, what would happen to how would our cases be reported? And in fact, almost a quarter of them would have been reported as heterogeneous, and the vast majority of them would have been in the cases that were called not amplified, so the not amplified results. So could this really be significant? So most of our not amplified cases had heterogeneity by that definition. But another interesting finding was that a lot of the equivocal cases, the ones that were close to the threshold for positive, had a very high rate of heterogeneity. And if you look at percent positive cells, you could see that the closer you get to the threshold for positive, so the equivocal cases, the ones close to the threshold, had higher percentages of those positive cells than the non-amplified by the average criteria. But if you look by immunohistochemistry and try to match up the results and say, well, is there really protein overexpression in these cases? The answer is no, very few. We do have equivocal cases, a very high rate of being 2+ positive, but not 3+ positive by immunohistochemistry. Now, if you flip that around and say, well, let's define an individual cell as by the signals per cell instead of the ratio, and then apply that definition of 5 to 50% of cells, you get a lot lower number. So instead of a quarter of cases, it's only 6.5%. And most of those were originally equivocal, so maybe a better definition in that sense. So a lot more overlap between equivocal cases close to the threshold being positive, being heterogeneous. And again, higher percentages of those cells in the borderline cases. And in addition, if you define by signals per cell, there's a higher rate of protein overexpression in those cases as well. So how you define the heterogeneity really can make a difference in how you're going to report these cases. And there's discordance between defining it by ratio and signals per cell in a big way. And what does that mean? Well, ideally, you'd have a clinical trial and say, well, what's relevant? Is it, the cases that were in the original Herceptin trials, some of them were HER2 negative by definition, and 8% of those actually did have a response to Herceptin. Were those the ones that were heterogeneous or close to the threshold? That would be ideal. But there are other ways we can look at sort of a more immediately available material. So how about looking at matched lymph node metastases and then the primary and say, is it evolving such that these minor clones are increasing in number in the matched lymph node metastases? So Carlos Suarez is one of our new faculty members, and he was a fellow when I was faculty at University of Washington. We started a project there, and he came down here, and so we've been working on that together. It's a poster outside today. So we looked at matched primaries and mets, and this is just the spread of overall the mean results, the reported results for HER2 that by ratio. We had very few cases that were in the borderline range, but that's sort of a normal spread. And then looked at the lymph node mets, and because the majority of our cases were not amplified to begin with by traditional definitions or amplified, we didn't have very many borderline cases, we saw a nice sort of linear relationship. Yes, the populations increased or decreased in the lymph node mets, but no cases were flipping. I think we only had one case that flipped from a negative to a positive result. And this is a nice diagram to show how the population, so the blue is the primary and the red is the met, and you can see that those populations go up and down, but you're not necessarily flipping from a negative to a positive In the vast majority of the time, it may not mean anything. But there are very few cases in that borderline category, and we see these in clinic. They aren't as common. They probably represent less than 4% of cases. Here's an example of a 39-year-old patient who had chemotherapy pre-surgery. She had a ER-positive cancer that was HER2 negative by one of the in situ techniques. And after treatment, she had a lot of residual disease. And so we retested her residual cancer. This is by immunohistochemistry. This is sort of a borderline high 2+ result. By immunohistochemistry, this is just to show you in contrast a nice 3+ result. So kind of on the high end of protein expression, but not a true positive. We did our FISH testing, and she was negative by ratio and was essentially equivocal because she had intermediate range HER2 signals per cell. But when you looked at the counting spreadsheets, you could count, well, 12% of her cells are amplified. She's got some in here with 10 HER2 signals per cell. I mean, these are amplified cells in this background. So we have standardized ways we're reporting cases like equivocal HER2 by FISH to mention what percent of the cells in there are actually HER2 positive, because that may bear some relevance. So when you get an equivocal result by FISH and you had an equivocal result by immunohistochemistry, the recommendations are keep testing until you get a non-equivocal result. We looked at her lymph node, and she ended up having an amplified overall result now in the lymph node metastasis with a amplified ratio and a low but positive mean HER2 signals per cell. So it can flip, I think. It's not easy to study these cases. Clinically, we're getting most of it right by doing these population averages. At least we assume we are. We haven't really looked at it in a clinical trial setting where we know whether those patients have responded to chemotherapy or not, and HER2-targeted therapy. The CAP-ASCO guidelines do specifically, the latest version, do specifically talk about heterogeneity and how they recommend scoring it. They don't recommend reporting the percent positive cells. They recommend only reporting cases as heterogeneous when you've got an obvious subclone. So here you can see by immunohistochemistry one area that's strongly positive for HER2 and another area that's more equivocal. Now, if I sent this for RT-PCR testing, just using the whole core, it would probably be HER2 negative. If I sent it for FISH and didn't specifically circle this area that's HER2 positive, I would get a negative result. So I think it's really important for the sort of in situ testing to see, okay, we do have a subpopulation of cells that are positive and we need to focus in there. So this is how we circle our cases when we see heterogeneity and say, okay, count this separately from this when we're looking at FISH. So in sum, I think the frequency of heterogeneity really depends on the definitions and the thresholds we're using for both individual cell results and population results, so cell populations. And the techniques that we use in scoring clinically can really make a big difference in terms of treat or not treat, and how we define which type of heterogeneity means something. I think heterogeneity can be a reason for a borderline clinical test result, and that's an important thing to reflect today clinically in our reports, and that clinical trials should think about these definitions more critically and try to determine the best thresholds for scoring. Additional considerations I think that are really critical for me as a pathologist and for all of us is, well, where do we sample to find these positive clones in cases that are heterogeneous? Are there tests we can do that are either imaging tests that tell us, pick here, biopsy here, or give us a more diverse look at the entire tumor? Or are there tests that we can perform on wherever our random biopsy was taken that will predict clinically validated tests where we can really predict that this is going to be a heterogeneous tumor and you may have to test multiple samples or do additional imaging to find out where to sample. But most of the cases, luckily in HER2, it seems like we've figured out the true positives and negatives. I think there's still a big gray zone in the middle. So I'm a pathologist, and I study pattern recognition and how we define things. And I'm sure you guys can see the owl, right, hidden in there. So where do we define where he begins and ends? All depends on how we set our thresholds and definitions. All right.
Okay, so we move on to the second speaker, and write down your questions in case you, like me, that you forget by the time we reach to the end. So that will have it. So we move to Megan.
Thank you. Try to be on time. I'll do my best. Thank you. So I'm going to give you really just a snapshot of epigenetic heterogeneity, looking at intratumoral heterogeneity of MGMT methylation, and just to highlight some points for further discussion on its potential impact on the outcome of treatment with alkylating agents. So I'm at the Stanford Cancer Institute at the moment, but much of the work that I'll show you was done in my former position at the University of New South Wales in collaboration with Dr. Kerry MacDonald, and our shared postdoc, Dr. Robert Rapkins, is the one who did most of this work. So I'm sure everyone's familiar with this, but aberrations of DNA methylation in cancer, what I'll talk about today primarily will be confined to these somatic methylation changes that are acquired during the neoplastic development process, but I will show one slide where there is methylation present in normal tissues that may also be etiological. And these changes generalizably can be described as the hypermethylation of CpG island promoters, and this is typical for the inactivation of tumor suppressor genes. And of course, there's global DNA hypomethylation across the genome, which has been shown to underpin chromosomal instability, as well as a few cases now showing through where there is overexpression of oncogenes associated with hypomethylation as well. So one classic example of aberrant DNA methylation in cancer, which really conforms to the simplistic notion that methylation affects both genetic alleles. This results in complete transcriptional loss of the gene expression and absence of protein, and thereby leads to a cancer phenotype, is the example of the MLH1 DNA mismatch repair gene. So all of these traces here are from a single patient. At the top, we have the colorectal mucosa that's normal, and beneath that, the primary colorectal carcinoma from the same patient. And here's at the MLH1 gene and its neighboring genes. And just to point out that these colors, red and blue here, indicate that the patient was heterozygous for a SNP within the promoter fragment that was analyzed for its methylation status. And these dots here show traditional clonal bisulfite sequencing, whereby each dot is a CpG site within the fragment of the promoter that's studied, and each line is a single allele, and black's methylated and white's unmethylated. So you can see that the normal colorectal mucosa is essentially completely unmethylated, and the primary colorectal carcinoma, at least for MLH1, is biallelically methylated because both genetic alleles are present and both have these dense black dots on. But you can see also that the neighboring genes are also variably methylated, which is possibly a passenger effect, but a mechanism that we've termed long-range epigenetic silencing, where entire regions are compacted. So this, of course, leads to loss of MLH1 expression and consequently microsatellite instability, where you have these altered lengths of tandem repeats due to the as a direct consequence of loss of mismatch repair activity, because the mismatch repair genes are not very numerate. So, or polymerase rather, is not very numerate, and in the absence of correction, you get these changes in repeat size. So this is the classic simple view, but is unfortunately not always the case. So why is tracing DNA methylation in cancers important clinically? Well, tumor phenotyping, of course, is one reason, and for a single test, which is MLH1 methylation, you can get all of this information. So MLH1 methylation basically is equivalent to microsatellite instability and the hypermutative phenotype because it indicates loss of mismatch repair activity. That is associated with improved prognosis, lack of response to 5-FU, but potential response to irinotecan. So by just doing methylation analysis of a single gene, that you can sort of harness all of this information. Methylation profiling can also be prognostic. Prime examples are the CpG island methylated phenotype, both in colorectal cancer and glioblastoma, where they're associated with lower stage and better overall survival. And for that, it involves hundreds of genes, but you can only you can use just select panels, or in the case of GSIMP for glioblastoma, look at IDH1 mutation, and you'll get the marker for this phenotype. Predictive of treatment response, MGMT methylation serves as the classic example because this sensitizes tumors to alkylating drugs, something I'll describe in a moment. And perhaps in our discovery phase still, we can identify the neoplastic drivers amongst those that are aberrantly methylated or hypomethylated, and I use drivers in a functional term so as not to to avert a flogging later as to my maluse. I have been re-educated in this regard. So, but of course, genetic markers have been used for their informativity for treatment selection or targeted treatment selection, how to best treat these patients, as well as for basket clinical trials. And epigenetics, it sort of completes the picture to some extent, at least, because you can have, for example, a hypermethylated P10 gene that will give you the functional equivalent of a P10 genetic mutation. So it's an important gap to fill in regards to the tumor knowledge. So in terms of heterogeneity of methylation, we've suspected this for decades because methylation patterns are just intrinsically variable, something we've been calling mosaic for donkey's years. Methylation in tumors is always under 100%. To some extent, this has been previously attributed to the contamination of tumor cells with normal tissues, so how pure is your tumor population? And we've had to thereby impose a methylation threshold for whether a tumor is considered methylation positive or not, similar to the FISH and immunohistochemistry described by the last speaker. So generally speaking, 4 to 10% of methylation will result in a notable immunohistochemical loss of protein expression. Another reason we've suspected tumor methylation heterogeneity in tumors is the presence of high levels of gene methylation do not always equilibrate or equal the absence of protein expression by IHC, and I'll come on to show you some examples of that for the MGMT gene in colorectal cancer and glioblastoma. So MGMT and its hypermethylation, just a little bit about this gene. It's observed in a high proportion of cancers, 25 to 40% across the spectrum, colorectal cancer, glioblastoma, lung, leukemias, you name it, it's found. It increases response rate to alkylating agents, and for glioblastoma, it's a predictive marker for an improved overall survival in patients treated with the alkylating drug temozolomide. And more recently, it's been shown by our group and others to be associated with a particular promoter enhancer SNP, both we've shown in colorectal cancer and glioblastoma. So MGMT methylation in the tumor and, in fact, at low levels in normal tissues is associated with this enhancer SNP. So here's a map of the promoter and enhancer of MGMT and exon 1, and here's the SNP located within this enhancer element. And this shows you a tumor where, just one example of a number of tumors where we've observed this discordance between immunohistochemistry and methylation status. So here we have a tumor that's strongly expressing MGMT, and yet when you look at the methylation status by allelic bisulfite sequencing, you can see that the tumor is in fact methylation positive. But let's assume that, but in this case, the methylation is monoallelic. Let's assume it's causing transcriptional inactivation for at least the majority of these T alleles measured on the reverse complement strand as A. But the remaining allele, which is still retained, there was no loss of heterozygosity in this particular tumor sample, the remaining allele was still obviously expressing the gene, and therefore protein was still present. So we selected all of our colorectal cancer cases from a cohort of 1,111 cases that were heterozygous for this SNP, which is present at 7.5% frequency in our colorectal cancer cohort. And 13 of these were discordant, i.e. had MGMT expression was present, but had this sort of a profile. So what this shows is that you can actually have heterogeneity of methylation patterns down to the allelic level. So you can have it, as I'll come on to show you, different components of the tumor, but within a particular cell, you can have one methylated allele and another not. We also have, looking at intrapatient heterogeneity of methylation in this gene, we have low-level methylation in normal tissues, and we found that this is highly predictive of the methylation status of their tumor. So just looking at this box here, we have peripheral blood, normal colorectal mucosa, and the colorectal cancer specimen for all of these matched pairs. And here we have a zoom-in plot of just the normal tissues, and you can see that there's levels of methylation at 1%, even up to 10% of the normal cells tested. And then, of course, in the tumor, this is highly predictive. And in a separate study, we've actually found that this SNP may, in fact, be predisposing to this subtype of cancer. So now just the last few slides, but the main focus of the talk here, really, save the best to last, is hypermethylation of MGMT in glioblastoma, where it is actually of clinical relevance. So in glioblastoma, it's dismal prognosis. So this treatment is one size fits all. The STUP protocol is radiotherapy and chemotherapy with temozolomide combined for everybody, irrespective of whether they have MGMT methylation. So MGMT methylation is associated with better overall survival of patients treated with temozolomide, but patients that are non-MGMT methylated also have an improved survival as well. So unlike the HER2 situation, we don't use MGMT methylation as a marker for selecting patients for temozolomide treatment. And here's how it works. So the temozolomide attaches to guanines, causes alkylation of the guanines, and if MGMT is present, this removes the guanines, and so you have a resistant tumor or resistant cells. Now, if the tumor or clones within the tumor are MGMT deficient, and this is presumed where you have MGMT methylation, the alkyl groups remain stuck on the guanine. These cause G to DT transitions. The mismatch repair system comes along, tries to repair them, but has this futile cycling, which then results in double-strand breaks and cell death. And so these cells with this type, or epigenotype, tend to be sensitive. However, what we found, this is just, again, a bird's eye view of what we found. Well, when we've looked at cases where we've had the primary tumor and the recurrent tumor, the MGMT methylation status has remained the same. However, in cases that did have an MGMT methylated primary tumor, the recurrent tumor had apparently acquired loss of DNA mismatch repair activity. So This could be a mechanism for acquired resistance to temozolomide and MGMT methylated clones. But more likely, the method we used in the recurrent tumours was a little bit crude, and so really just didn't find the low-level heterogeneity of the clones that had both MGMT methylation and mismatch repair loss within the primary tumour, and perhaps that was pre-existent and they were resistant to begin with. That we haven't differentiated between. However, when we looked at intratumoral MGMT methylation, we did find some heterogeneity just from 7 cases where we performed all of these tests. So they were heterozygous for the SNP so that we could trace allelic methylation. We tested them by IHC, looked for loss of heterozygosity, and did methylation pyrosequencing and clonal bisulfite sequencing. We found that 4 were discordant in that, so here highlighted in blue, discordant in that they went, so one sample of the tumor was methylation positive, another sample of the tumor was methylation negative. So you perhaps have these clonal foci at spatially different compartments of the tumor, and one showed just this wide variation where 8% would have been considered positive, and another, but that didn't change a positive or a negative call. So this, of course, has implications as to where you might sample a tumor, or do we need to do multiple sampling of tumors to get a true result. And this is just illustrated further with clonal bisulfite sequencing. This was patient G, where we saw a wide variation. Sorry, actually, this was patient G where we saw discordance. One part of the tumor was positive, another part negative for methylation status, and you can see this profound difference in methylation between the 2 samples of the same tumor. Here we just had differing levels, but interestingly, you can see that again, methylation is confined to one allele of the gene, and it's at this particular SNP site. And the MGMT protein by IHC was present despite this substantial level of methylation. So in summary, we found both monoallelic MGMT methylation in some tumors, and that this can account for a methylation positive tumor that nevertheless has protein retention. So which result is more important in calling it, positive or negative? We found mosaic MGMT methylation in normal cells, and not just confined to MGMT. We found this for MLH1 and a battery of other genes. But in this case, we believe it predisposes to the tumor development. And it certainly is predictive of tumor phenotype. We've also found discordance in MGMT methylation results between different samples of the same primary glioblastoma. So is multiple sampling of tumors necessary, and does this impact on sensitivity or resistance to targeted therapy? Quite possibly it does. So that's where I will end. Thank you.